you can go for a curative surgery also while doing a diagnostic lab. So endoscopy and endoscopic ultrasound, you can go through all these things because I already mentioned all these things. And CT, so some points about the proximal gastric cancer I have told you. This proximal gastric cancers is an endemic variety. It is not environmental or a diet related. Diffuse type, that means it is a very malignant type. It has got a bad prognosis. Intestinal type has got a good prognosis, but this is a proximal gastric cancers are diffuse type and it has got a bad prognosis. Resectability is 20% and needs total gastrectomy. So that is all about, because all proximal tumors, proximal gastric cancers need total gastrectomy. Then coming to distal gastric cancers. All distal gastric cancers are diet related, environmental. It is an epidemic variety. It is because of the dysplasia of the cells. Intestinal Lawrence classification comes. It has got an intestinal histology. It has got a better prognosis. Resectability is 30% and it needs distal subtotal gastrectomy. Needs distal subtotal gastrectomy. So this is all about distal tumors, distal gastric cancer. Then coming to the management. Management is always surgery. Resection of tumor and reconstruction of the structures. So that is the treatment. Resection of the tumor and then reconstruction. So what all the resectable case? Curative surgery we can do it only on resectable case. So T1 and T2 lesions are the resectable case. That means involvement of the mucosa, and T2 lesion means it has just invaded the muscles of the stomach. These lesions, but it hasn't invaded out to the serosa. So up to the muscles it has reached, but not outside the serosa. So these T1 and T2 lesions are resectable case. In that case, you can remove the stomach along with the tumor, and the D2 is lymph node dissection. D2 means, first D1 means perigastric nodes. D2 means the nodes along the celiac trunk and splenic artery. So the curative resection is D2 gastrectomy plus adjuvant chemoradiation is the ideal treatment. So I'll tell about what type of gastrectomy. According to the site of lesion, you have to decide. According to the site of lesion, you have to decide what type of gastrectomy you have to do. Okay. So what is the ideal treatment for a resectable case? D2 gastrectomy plus chemoradiation. That is the ideal treatment for carcinoma stomach. If the lesion is only confined to the mucosa, you can go for an EMR or ESR, endoscopic mucosal resection or endoscopic submucosal resection. That is, with a margin of normal mucosa, you have to remove the lesion, and regular follow-up is needed for the patient. While doing endoscopy itself, you can do this EMR or ESR. Then the other type of gastrectomies are total gastrectomy, subtotal gastrectomy and hemigastrectomy. If the lesion is on the upper part of the stomach, you have to go for a total gastrectomy. If the lesion is on the lower part of the stomach, you have to go for a subtotal gastrectomy. If it is almost, or sometimes you can go for a hemigastrectomy also. According to the site, you have to decide what type of gastrectomy you have to do. Subtotal gastrectomy means more than 80% of the stomach is removed. Hemi means up to more than 50% is removed. Total means the whole stomach is removed. So these are the surgeries we offer for carcinoma stomach. EMR or ESR, total gastrectomy, subtotal gastrectomy, or hemigastrectomy. Okay, structures removed in gastrectomies. Stomach with deletion. Wherever be the site, you have to remove stomach with the growth with a 5 centimeter proximal clearance. So the upper part you have to leave 5 centimeters from the growth, and in the lower part you have to leave 2 centimeter from the growth. So the growth may be 1 or 2 centimeter or 5 centimeter like that. That growth from the upper part of the growth, you have to leave 5 centimeters of normal stomach, and from the lower part of the growth you have to leave 2 centimeters clearance. In that way you have to cut the stomach, and along with that you remove the omental bursa, greater and the lesser omentum, anterior layer of the transverse mesocolon, anterior pancreatic capsule, and the lymph nodes. Lymph nodes, D2 lymph node. What is D2 lymph nodes means? The perigastric nodes means 1 to 6 nodes are in the perigastric region. Then 7 to 11 group of nodes also you have to remove. So that is D2 lymph node dissection. That is what we are doing if we are doing a gastrectomy. So structures removed in gastrectomy are stomach with the lesion, 5 centimeter proximal normal mucosa, normal stomach, and 2 centimeter distal stomach. Distal to the growth you have to go for 2 centimeter, clamp it, and proximal to the growth you go for 5 centimeter and clamp the stomach, cut it and remove it, along with omental bursa, greater and lesser omentum, anterior layer of transverse mesocolon, anterior pancreatic capsule, and the lymph nodes in the perigastric region and along the celiac trunk and the splenic artery. If it is an inoperable case, that means T3 and T4 lesions, in that case you can do only palliative procedure. You cannot remove the growth from the stomach bed. So that time you go only for a palliative procedure, otherwise you will end up in complications. So in case of inoperability, if you see any signs of inoperability, you go for a palliative procedure. Then what are the signs of inoperability in a carcinoma stomach? Adherence of the growth to the pancreas posteriorly, or to the colon anteriorly, or to the mesocolon. Ascites, presence of ascites, involvement of the para-aortic lymph nodes. When you do a CECT abdomen, there may be involvement of the para-aortic lymph nodes. If you see that, don't go for any curative surgery. Secondaries in the liver, that means M1 is stage 4. M1, it is stage 4. So any palpable mass is incurable. Palpable mass in the sense it has infiltrated to the serosa and the surrounding tissue, but can be resectable. Palpable mass is incurable but can be resectable surgically because it has infiltrated anteriorly, not posteriorly. If it has infiltrated posteriorly, very difficult to lift the mass from the bed and very difficult to release it and do the anastomosis. Then whenever there is Blummer shelf, don't do any curative surgery. You go for palliative surgery only. Whenever there is systematic Joseph nodule or a left supracollateral node involvement or an Irish node, you go for only palliative surgery. Then the surgical options are, I have already told you that SMR, endoscopic submucosal resection or EMR, hemigastrectomy, subtotal gastrectomy or total gastrectomy. Then guidelines for EMR or ESR. All intramucosal tumors, that means tumor limited to the mucosa of the stomach, any size without any ulceration, you can go for EMR or ESR. And differentiated, it is not differentiated, not poorly differentiated. So low grade mucosal tumors less than 3 centimeter with or without ulceration, you can go for EMR or ESR. And limited submucosal invasion with size less than 3 centimeter without ulceration also, you can go for EMR or ESR. These are the indication guidelines for endoscopic resection. Then coming to the surgical distal 1/3 tumor. That is, whenever there is a distal tumor in the pyloric region, you go for a distal gastrectomy. I already told you hemi or a subtotal gastrectomy. While doing a subtotal gastrectomy, what you are removing is the part of stomach with the growth 5 centimeter above the lesion and 2 centimeter below the lesion, along with the greater omentum, lesser omentum, transverse mesocolon, all these structures. Okay, you can, in the diagram itself, it is dotted line shows all the surrounding structures. So once you remove this much of tissue, then you have to restore the continuity of the stomach and the duodenum. Okay, and how will you restore the continuity? By doing anastomosis. I will show you next slide. In middle third of tumor, it is subtotal or total gastrectomy. If the growth is very big, then sometimes you may not be getting 5 centimeter clearance. When you go for a 5 centimeter clearance, then you have to do a total gastrectomy. If it is a lower part or a small tumor, then you can go for a subtotal gastrectomy in case of a middle third tumor. Then proximal 1/3 tumor, always you go for a total gastrectomy. Proximal 1/3 tumor, you have to go for a total gastrectomy. The extent of lymph node dissection, I have already told you that there are so many groups of nodes are there in this for the stomach. So D1 means 1 to perigastric nodes. That is 1 to 6 group of nodes are known as D1 nodes, and D2 means 7 to 11 nodes are also included. D1 plus 7 to 11 nodes, that is nodes along the splenic artery and the celiac artery. So that is D2 dissection. So for a carcinoma stomach, we remove the lymph node from 1 to 11. That is called D2 dissection. All the perigastric nodes and the nodes along the hepatic, celiac and the splenic nodes splenic arteries are removed. That is called D2 dissection. Then what is D3? D3 is at the level of mesenteric, root of mesentery, that is superior mesenteric artery. Till that region you have to go and remove. That is the 12 to 16 group of node. From 12 to 16 number you have to remove. Then D4 is D3 plus para-aortic node removal. That anyway we will not go up to that region. We will go up to D3 dissection for a betterment of the patient. This will reduce the morbidity. If you go very, very deep, the complications will end up in complications and the morbidity of the patient is also more. Then if you have any doubt, you can ask me. This is also I have taken from the SRB. Presently the D1, D2, D3, D4, I already mentioned all these things. Commonly done is D1 or D2 dissections. D1 in the sense it is the perigastric nodes, and D2 is nodes along the celiac, hepatic and the splenic artery. Nodes at that region. What is N0? When there is no nodal involvement. What is N2? There is involvement of the 1 or 2 nodes in the perigastric region. So when the patient is N1, that means when the perigastric nodes are involved, you go for a D2 dissection. ഒരു ഓടുന്ന പട്ടിക്ക് ഒരു മുഴം നീളെ എന്ന് പറഞ്ഞു കേട്ടിട്ടില്ല, അതേപോലെ N1 എന്ന് പറയുന്നത് പെരിഗാസ്ട്രിക്കിൽ 1 or 2 ഗ്രൂപ്പ്സ് ഓഫ് നോട്ട്സ് ആർ ഇൻവോൾവ് ആണ്. അങ്ങനെ അപ്പോഴേ കാണുന്നു എന്നുണ്ടെങ്കിൽ യു ഗോ ഫോർ അതിന് മുകളിലത്തെ ഇൻ്റർമീഡിയറ്റ് ഗ്രൂപ്പ്സ് ഓഫ് നോട്ട്സിൽ പോയി ഡിസെക്ഷൻ ചെയ്യണം. സോ ദാറ്റ് ഈസ് D2. So that by doing a D2 dissection, we are removing 11 groups of nodes. 1 to 11 groups of nodes are removed by doing this D2 dissection. So that is enough for a better survival of the patient. This is again, I wanted to make you understand. D1 is perigastric nodes, that is 1 to 6. D2 nodes along the celiac, hepatic and splenic artery region, that is 7 to 11. D3 is nodes along SMA and hepatoduodenal ligament, that is 12 to 16. Then steps in total gastrectomy. Now I wanted to tell you, I have already told you what all structure, how the gastrectomy is being done. Now you have to make the continuity of the canal. From the stomach, the food should go to the jejunum or duodenum like that. Duodenum and jejunum like that. So how the continuity is maintained? When you are doing a total gastrectomy, so you are removing till the first part of duodenum, you are cutting. From there to esophagus, you put another clamp. You put a clamp in the duodenum and you put a clamp in the esophagus, and you are removing the whole stomach out. So now you have what is the cut end of stomach, esophagus, and the cut end of duodenum. So you, after total gastrectomy, you make an anastomosis of Roux and Y, esophagojejunostomy. How the jejunum comes there? Because duodenum is a retroperitoneal organ. It is a retroperitoneal. We cannot pull the duodenum to esophageal hiatus. So that time what you will do? You will take jejunum. See, this is the stomach you have already removed from there. You have the duodenum, C loop of duodenum like this. This is the upper end, you can see the esophagus, and you make an anastomosis there, esophagojejunal anastomosis. How the jejunum comes there? So this is the duodenum, C loop of duodenum, and after that the jejunum starts. You make a cut in the jejunum and the distal part of cut jejunum. So the jejunum now has got a proximal jejunum close to the duodenum and the distal cut end of jejunum. That jejunum you bring upwards and anastomose with the esophagus, and the cut open end of duodenum you close it by doing a sutures, putting sutures and close the opening of the duodenum. And the C loop of duodenum comes, ligament of Treats, and then the jejunum. At jejunum, you anastomose end to side with jejunum. So jejunum is anastomosed to jejunum. That is jejunojejunostomy. Jejunojejunostomy. So that is how you make a Roux and Y anastomosis. Now you got it. Once you remove the whole stomach, you get the cut end of esophagus and cut end of duodenum. The cut end of esophagus should be anastomosed to the jejunum. For that, you make a cut in the jejunum. after 35 centimeters from the treats ligament, you cut the jejunum into, make a cut in the jejunum. The distal limb, you pull it upwards and anastomose to the esophagus. Then here the duodenal opening is, first part of duodenum is closed by putting sutures. So whatever bile produced from the CBD liver go with the, in the second part it will collect, it will go like this to the jejunum. That jejunum you anastomose end to side, end of that jejunum to the side of the jejunum, which is anastomosed to the esophagus. That is called jejunostomy. So Roux-en-Y anastomosis, what you do is Roux-en-Y esophagojejunostomy. That is the reconstruction we are doing after total gastrectomy. Roux-en-Y esophagojejunostomy and jejunostomy. That is how you make continuity of the stomach, not the stomach, the GIT. Then subtotal gastrectomy. So what do you do in subtotal gastrectomy is, a part of stomach is removed. So part of stomach will be there after the surgery. So you remove the growth with the stomach 5 centimeter upwards and 2 centimeter downwards, put 2 clamps, cut along with the lesser omentum, greater omentum and the transverse mesocolon and omental bursa, pancreatic capsule, like that. All these structures you remove it along with the lymph nodes, D2 lymph nodes, and then after the surgery you will get a portion of stomach like this, then the part of duodenum, then the part of duodenum like this, and yes, part of duodenum along with the and jejunum like that. So how you reconstruct the GIT is by doing a gastroduodenal anastomosis, that is called Billroth 1, or by doing a Billroth 2 surgery, that is loop gastrojejunostomy or Roux-en-Y gastrojejunostomy. So when you see this diagram, so this is a part of stomach is there and this is the C loop of duodenum. That duodenum comes then jejunum. This jejunum is pulled upwards as a loop and you make a longitudinal incision in the jejunum and anastomose with the stomach. That is Billroth 2 anastomosis. Forget about anticolic and retrocolic and this is the anastomosis, gastrojejunostomy. That is Billroth 2. And another anastomosis is also possible, that is gastrojejunostomy or Roux-en-Y gastrojejunostomy. Just like the first this thing, you can first this is Billroth 1 is gastroduodenostomy. That is the C loop of duodenum, the cut end of duodenum is there, the cut end of stomach is there. So the stomach can be pulled down and the duodenum opening can be anastomosed according to the lumen of duodenum. The lumen of the cut end of the stomach can be sutured to make a lumen like this and it can be anastomosed with the duodenum. That is known as Billroth 1. But we are not doing Billroth 1 because the chances of biliary gastritis is more. So we are not doing Billroth 1. So forget about Billroth 1. That is gastroduodenostomy. That is Billroth 1. So we are not doing this surgery because of the complications of biliary gastritis. So forget about that. Concentrate only on Billroth 2. Then in two ways we can make a Billroth 2 anastomosis. That is, first you close the cut end of duodenum. Close the cut end of duodenum. Then after 50 centimeters, you take one loop of jejunum, anastomose with the open end of stomach. That is Billroth 2 gastrojejunostomy. Billroth 2 gastrojejunostomy. Then another way of anastomosis reconstruction is just like the first case, you close the cut end of duodenum. Then after 35 or 50 centimeters, you can cut the jejunum. The distal end you anastomose with the stomach, and the duodenum portion with the jejunum you make a jejunal anastomosis. Gastrojejunal and jejunal anastomosis. The first Billroth 2 is gastrojejunal anastomosis only. Here anastomosis 2. One is row and while you will get a gastrojejunal and jejunal anastomosis. That is how you maintain the continuity. Then the same way you can do it under laparoscopy also. So laparoscopy, advantages of laparoscopy, you know. All these things are the advantages of laparoscopy. While doing a diagnostic lap itself, you can plan for a laparoscopic resection. If it is a resectable tumor, accordingly you can do a total gastrectomy and anastomosis, or a subtotal gastrectomy and anastomosis. And nowadays robotic assisted surgery is also there. It has got more advantages. You can go through all these things. Then after all surgeries, you have to go for it. You have to give chemotherapy to the patient. These are the two regimes we follow. These drugs you have to give in cycles to prevent a local recurrence and distant metastasis. Then management of gastric carcinoma, you can just read, and if you have any doubt you can ask me. Then the palliative procedures. One word, that is palliative surgery. See, palliative procedures. Palliative procedures, I already mentioned that T3 and T4 lesions, we only go for palliative procedures. We will not go for a radical gastrectomy or a total gastrectomy or a subtotal gastrectomy. We won't perform all these things. We just do a palliative partial gastrectomy or an anterior gastrojejunectomy or Devine's exclusion procedure or some stenting like that. This only we do. So this is the Devine's procedure. The growth is infiltrated to the surrounding structure, so you cannot lift the pylorus from the stomach bed. So in that case, what you do is you keep the tumor like this and do a gastrojejunectomy. Partially resect the tumor separately from the stomach so that it will not infiltrate to the anastomosed portion. So you make a jejunectomy, that is Devine's exclusion procedure. And otherwise you can just make an anterior GJ without cutting the stomach. You just make an incision and do a anterior GJ so that the patient can eat well and eat well for some more time. To relieve the obstruction, you are doing this palliative procedures. Then after that, you have to give palliative chemotherapy also. All these medicines you have to give to prevent for a better survival of the patient. So one should remember what all things. 6 centimeters. So we are following 5 centimeter margin clearance of the tumor is recommended proximally and 2 centimeter distally. T2 lymphadenectomy is essential and resection of greater and lesser omentum is necessary. Splenopancreatectomy only in indicated cases. Otherwise, you won't remove spleen or tail of pancreas. Because if you remove all these things, you will end up in more troubles. For proximal lesion, varying length of esophagus should be excised. Judicious decision should be taken for total, proximal and distal gastrectomy, and all patients should receive chemoradiation. So that is all about carcinoma stomach. And screening, as a screening procedure of high risk patient, you can advise yearly endoscopy like that. Okay, any doubts you can ask me. Okay, that is all about carcinoma stomach. If you want to revise, so histological types are 90% are adenocarcinoma, and signet-rich cell carcinoma is the most malignant form of adenocarcinoma. Pathological classification: Borman according to the macroscopic, Lauren according to the microscopy, and WHO system according to the pathology. And Borman is 5 types according to the macroscopic appearance. WHO classification: adenocarcinoma is the most common. It is papillary, tubular, mucinous, and signet ring. That is, signet ring is most malignant tumor. And Lauren classification: intestinal type and diffuse type. Diffuse type is more malignant and more worse tumor. And clinical features: more than 70% are asymptomatic. When the symptoms comes, it become inoperable case. And what is system: Mary Joseph nodule, Irish node, and 5 modes of spread are there. And staging is TNM staging. TNM staging, that is T1, T2. T1 is confined to the mucosa, T2 is infiltrating to the muscles, T3 is whole muscle involvement and up to the serosa, and T4 is to the surrounding structures. And nodal involvement is N1 is 1 or 2 regional lymph nodes or perigastric nodes, N2 is 3 to 6 regional lymph nodes. That means N1 and N2, the lymph nodes in the perigastric region. N3 means it is in the intermediate group of nodes. In that, 7 to 15 nodes are N3A, and more than 15 comes in N3B. M1 is distant metastasis. And T2, T3, T2 and T1 lesions are operable lesions, and you have to add chemotherapy also. T3 and T4 lesions are, you do only palliative procedures plus chemoradiation. Now you know what all the palliative procedures. And palliative procedures, these are the Devine's procedure, then anterior GJ. You keep the lesion there and do a drainage procedure, and along with that you have to add chemoradiation. And T1 and T2 lesion, you can go for a EMR or a ESR, or a total gastrectomy, or a subtotal gastrectomy, or a hemigastrectomy. Along with that, you have to give chemotherapy also. Investigations, I already told you what all the investigations you have to do. Then along with the surgery, you have to do the drainage procedure. The drainage procedure, that is, what are structures removed in gastrectomy, I have already told you. Then the reconstruction of the stomach after total gastrectomy is by doing a esophagojejunostomy and jejunojejunectomy. After total gastrectomy, you do a esophagojejunostomy and jejunojejunectomy. And after subtotal gastrectomy, you do 2 types of anastomosis, Billroth 1 and Billroth 2. Billroth 1 we are not doing, that is gastroduodenostomy. The Billroth 2 we are practicing. In 2 ways we can do a Billroth 2. One is gastrojejunectomy, the other one is Roux-en-Y, gastrojejunectomy plus jejunojejunectomy. So that is all about carcinoma stomach. So first I have told you about a case history, case scenario. the patient is having a carcinoma stomach, if the patient is having a lesion showing, if the patient is having vomiting, that means the patient is having a obstructive features are there. So in that obstructive features are there, then you have to assess by doing a CACT, endoscopy, EUS like that. Then you have to plan accordingly. If the what is the tumor grading, if it is T2 or a T1 lesion, you can go for a curative surgery like subtotal, because lesion is in the lower part, so you can go for a subtotal gastrectomy and reconstruction. Along with that, you have to give chemotherapy also. Post-operatively give chemotherapy. Okay, that's all. Thank you.